Well, ladies and gentlemen, thank you so much for inviting me back to Cairo, which I seem to be enjoying from the office of my own home at the moment. Um, uh, but thank you again for inviting me to the conference. Um, when we talked about this a few months back, I was running the London COVID Cancer Hub, and I thought it might be quite good to give a little talk as to what our experiences in London. But of course, I'm sure all of you here would be able to give a similar talk in your own unit. Um, uh, um, and I hope hopefully there'll be some discussion at the end. I've entitled this talk "The Royal Marsden Cancer Hub in COVID-19." My name's Thomas Ind. I work at Royal Marsden Hospital and the Institute of Cancer Research, as well as St George's University of London. You'll probably be aware that I'm a great supporter of SERGs, and I have no disclosures on this comment, other than the fact that I was chair of the Gynaecological Oncology side of the Royal Marsden London Cancer Hub. So no relevant disclosures to this presentation, other than the fact that I do hope you'll all come to Svegborg in Denmark on the 23rd of September. I think this has been a great timing because this will be a face-to-face conference. It will probably be a little bit hybrid, but I think it will be the first one that we go to. The abstract submission deadline is May the 31st. And the early registration deadline is June the 30th. I'm going to start with this slide. And this slide looks at the number of deaths in England and Wales for 53 weeks in a year. Yes, and the reason it's 53 is every 5 years we have 53 weeks, not every other year we have 52 weeks. It's just the way the statistics are collected. And you can see that there were 6 weeks in April when our death rate surged and we were having over 10,000, nearly 15,000 additional deaths every week in the coronavirus epidemic. And as you can see, this crept up again just before Christmas. This has caused a huge amount of difficulty in terms of running cancer services. And what I'm hoping to do today is explain to you how we've managed it so far. In fact, we're in another surge at the moment, which is probably worse than this. And I'll demonstrate that to you in another slide. But it's caused a bit of gallows humor. I'm sorry if you've already seen this, but I've got to play it.
Because of coronavirus, you are going to be quarantined, but you have a choice. Do you A, quarantine with your wife and child, or B.
And I think some of you may identify a bit with this guy, because it's been hard for all of us, both staying at home psychologically, managing our teams psychologically, and the social distances that we've had to go through. So I need to begin to explain to you the different sectors in London, which aren't really the same in the rest of the UK, because we have a large international practice. A lot of people travel to the UK for treatment, and of course they weren't doing that in COVID. So we have our National Health Service. Pretty well most respectable gynae-oncologists work in the National Health Service, although they may want to supplement their income in the private sector. The National Health Service is where most people work. But the problem is that most accident and emergency hospitals most NHS hospitals have an accident and emergency department, and you cannot choose who turns up at your accident and emergency department. And if more people turn up than you have resource for, then it takes over the other elective work. Now, one or two hospitals and Royal Marsden Hospital, which is one of the hospitals where I work, don't have an accident and emergency department. And our next door hospital is the Brompton Hospital, but they contain the ECMO machine. So they were taking, end stage COVID patients. We then have a number of private hospitals. Some are owned by private companies, such as the Hospital Corporation of America, Aspen, which is owned by, I think, a company in the UAE. and then a few charitable-based private hospitals such as King Edward VII and the London Clinic. And then we built 5 Nightingale hospitals. So the Nightingale Hospital in the UK at the Excel Centre was built in a few weeks and designed to look after 4,000 supposed intubated patients. That this was a failure. Unfortunately, we only used 26 beds in the first wave, and we've only used 5 beds in the second wave, mainly because you need the staff to work there. And also, you know, once you've got a critically ill patient in a hospital, it's very difficult to transfer them across London. So this hasn't been the useful resource that we were hoping it would be. So this is the current wave. Now, we didn't have these statistics earlier on, but you've got to understand how this impacts every part of the journey. So these are the daily admissions to hospital for coronavirus. So these are people with a diagnosis of coronavirus. And this is starting at the beginning of August, once the first wave was over, and culminating to the 15th of January. You can see in the last few days it's come down a bit, to great relief. But of course, the maximum deaths will be next week. So these are the admissions to hospital with coronavirus. And as you can see, we were up to 1,000 admissions a day. This is just London. This is not UK. This is 1,000 admissions a day in London with coronavirus. And of course, you can't possibly look after anyone else because there are no beds for anyone else. The ventilators are having to be taken out of theatre, and it just completely overwhelms the hospital. And to run a cancer service, it's got to be run somewhere other than an acute hospital, and nearly all NHS hospitals are acute. The problem with London is that it's an old-fashioned city not designed for social distancing. Most healthcare workers have to take the tube into work, and it's a crowded thing. The buses are crowded, even the hospitals are crowded, and we've had an epidemic based in hospitals as well as in the care of the elderly services in elderly care homes. So to understand how we dealt with this, you need to understand a bit about how gynecological oncology services are delivered in London. So we have 5 main regions in London. Which has a population of 9.2 million. So it's a really big city. New York has only 8.4 million. It's about the same size as Cairo, which has 9.1 million. I know it depends on whether you look at greater, metropolitan cities or the greater area of a city, but this is from the same table analysing population. And we have the Hammersmith Hospital, which is part of Imperial University, which covers the London boroughs of Harrow, Hillingdon, Brent, Ealing, Hounslow, Hammersmith and Fulham, and it has tentacles out to Berkshire and Buckinghamshire. We have the joint centre of Royal St George's and Royal Marsden Hospital, which is under the auspices of the University, St George's University of London and Institute of Cancer Research. This is, we serve the boroughs of Kensington, Chelsea, Wandsworth, Richmond, Kingston, Croydon, Merton, Sutton, but we also have tentacles out to Surrey and West Sussex. There is St Thomas's Hospital, which is in King's University, which covers the boroughs of Lambeth, Southwark, Lewisham, Bromley, Greenwich and Bexley. Busy hospitals with A&Es. They have tentacles out to Kent. We have the Royal London Hospital, which used to be at part of Queen Mary's Westfield University. They cover the City of London, Tower Hamlets, Waltham Forest, Newham, Redbridge, Barkham and Dagenham and Havering. And they have tentacles out to Essex. And University College London, which is based in Westminster. It's part of University College, so University College Hospital is part of University College London, and they cover the boroughs of Westminster, Camden, Barnet, Haringey and Enfield, and they have tentacles out to Hertfordshire. So not only do the London hospitals cover the whole of Greater London, but they also cover some areas in the surrounding counties. And all these hospitals, with the exception of the Royal Marsden Hospital, has an A&E. And because of different areas, some hospitals were overwhelmed first. So there's a hospital called Northwick Park Hospital, which is about where my arrow is here, but was the first to become overwhelmed. We initially moved to the London Cancer Hub, but only 3 days later we divided it into 2 hubs because we realized it was unworkable. And the main reason we did this is, first of all, this region, all but one of their surgeons had COVID at one point. The same applied to this region. We now know retrospectively that one of the female surgeons in the region where I work did get COVID, but she was asymptomatic, and we discovered that on antibody testing. So we developed into 2 cancer hubs, and to begin with, I looked after what we called the Royal Marsden London Cancer Hub, which was, southwest London. There was another hub in northeast London. Now, there were problems. Ventilators were confiscated in many of the hospitals which didn't have A&Es to send to the Nightingale hospitals, and staff went there too. We operated at Royal Marsden Hospital in Chelsea and the Cromwell Hospital in Chelsea. That was the only 2 hospitals with resource covering half of London in the main surge of COVID. It's only a few weeks because other hospitals reopened afterwards, but those were the hospitals we predominantly worked in during the main surges. And we had gynecological oncology teams from Imperial, but as I said, a lot of them had gone down with COVID. St Thomas's, and as I said, a lot of them had gone down with COVID, and the Royal Marsden Hospital. We did later on, some people from St Thomas's overtook the London Bridge Hospital. We had other hurdles, which I know many of you also had. Not only did staff go ill, in my unit, 48% of our staff contracted COVID. They initially banned minimal access surgery, and we were a heavy robotic unit. And it meant that we were having to do things open that we would normally do minimal access. And that was because there was concern over aerosol procedures in minimal access surgery. Now, that was eventually debunked, but only after a lot of very expensive contained insufflators were purchased. And of course, we still have those now. They have other benefits. Our turnover time increased because we had to wait half an hour between the end of one patient and the beginning of another patient. And we had to operate in PPE, which was tiring and difficult. And we had to do social distancing. So here is operating in PPE. You can see this is on the 26th of March, which was the day we really went into lockdown. And as you can see, I'd been issued with a ventilator because none of the FFP3 masks fitted me at that time. I subsequently was able to get one that did fit me. But you can see, and here are my 2 registrars operating on a case, how difficult it is operating in PPE, how restricting it is. And of course, social distancing is difficult. I've used this photograph. This is Marinella. Poor Marinella went down with COVID yesterday, just after she got the vaccine. So our thoughts are with her, but she's young and she's a lady, and I'm sure she'll do all right, but we thoughts were with her. We always celebrate our 100th anniversaries, and this was our 900th anniversary of a robot case. In fact, we're about to celebrate 1,000. But instead of having a cake, bringing a team together, because we couldn't do that, we made cupcakes. This is our main coffee room, but only 3 people were allowed in there at any one time. And of course, when the operation finished, we had to send all our surgeons to different parts of the hospitals because they weren't allowed in the same room as each other. And then they had to somehow know when to come back to start the next operation. So social distancing became an issue. And we didn't initially have great Wi-Fi. We didn't have fabulous Wi-Fi. We were worried about the confidentiality of Zoom meetings, and the like. So there were all of those issues, and I know all of you have encountered these problems too. So we decided that we were going to prioritize, and these were the priority groups. So all the colleges and the specialist societies came together, and we used these 5 priority groups, priorities 1A and 1B. 1A being emergency surgery, for example, a perforated bowel. If you didn't do it, the patient would die. 1B should be done within 24 to 48 hours. Bowel obstruction for ovarian cancer was the classical one in gynecology. Priority 2 should be done in less than 4 weeks, and that's most primary cancers, not in group 3. Group 3 were those we felt could wait 3 months, and that would be cervical cancer stage 1A. We said they could wait 8 weeks. Repeat conization after high-grade precancer, simple hysterectomy following cancer for a conization, low volume, completely excised cancer, low-grade stage 1A uterine cancers, which were managed with oral progesterones and IUSs, and ovarian cancer, which we felt could be treated with neoadjuvant chemotherapy with equal efficacy. And I'm afraid this initially included most surgery for recurrences, but in fact we changed that because some of the cervical cancers were having curative surgery. We then had group 4, which are those that could wait 3 months, and that is reversal of stomas and risk-reducing surgery. In other specialties, reconstruction for breast cancer was abandoned. A lot of the prostate cancer work was put into category 3. This was controversial, but at least it was across the board. It was agreed by the British Gynaecological Cancer Society, so we had medico-legal backing, and we made a decision that no one should be able to buy their way up a queue. So everyone was prioritized and everyone was done in order, whether they were a private patient or an NHS patient. I'm very proud to say that you couldn't get an operation quicker just because you're a private patient. I think that would have been very bad if that was the case. In that 8-week surge, we only did 1 emergency. We had 3 other urgencies, but the vast majority of our cases were P2 and were done. Of our P3, we had 12 endometrial and 18 ovaries, and they all got their surgery eventually. And there were 12 that we know of who could wait 3 months, but we think a lot of those patients didn't come forward. And of course, the diagnosis of a lot of these cases was deferred because a lot of people didn't want to come to hospital. So this has been the problem we've got now, is that we're doing catch up with diagnoses. We've got bigger cases and we're really in the thick of it now. So I really apologize, guys, that I'm not attending most of this conference except to give my talk, but we are in a worse position in London now than we were in April. We're having 15,000 deaths a day in some cases in the UK. And I'm afraid I've got to go back to work. But I will stay around if I can for questioning if we're running on time. We've had cancellations due to COVID, but we've got most of those done. We have had a few COVID deaths. There is, however, hope. Definitely hope for me, because I've had both doses of the Pfizer vaccine. As I'm sure you're aware, rather controversially in the UK, it's only 1 dose now until everyone is vaccinated, and that's very controversial. I'm sure other people have had similar experiences. I wish everyone a very, very safe 2021, and I hope we conquer this. Stay safe, everybody. And if you're not in a surge, think of us in London, because we definitely are at the moment. So that's the end of my presentation, and hopefully there'll be some discussion and we can hear about other people's experience.